This conference will now be recorded.
The topic that I've chosen is with the focus on India. It's nutrition in developing countries. Uh, Although the focus is India, you can use this in most other developing countries also. The issues are pretty much the same. So keep that in mind. And I'm going to take my webcam off so you can see the presentation. Okay. And I'm just going to put it onto slideshow. Okay. So the one thing that I want to talk about, and I think it's really important, and it's just coming up in nutrition with programs like Saybrook University, is an integrative approach to nutrition. And I think that, we have to just stop looking at just one problem and focus on this, because there are many factors that will impact a more comprehensive approach, and they will also offer many more permanent solutions. And in my work in India, where I worked in two locations, in an urban location in the city of Bangalore, and up in the foothills of the Himalayas, where it was a small town and there were a lot of neighboring towns nearby. And I felt like the integrative approach was absolutely crucial to, help the people with whatever issues they had. So I would like you to think of social, economic, cultural issues when you look at somebody who has a nutritional issue. And this next slide here I'm showing you is one of the foothills villages near where I lived, in a little more crowded town. But these villages are extremely isolated. Usually, it takes a lot to access these villages because there's no motorable road. And I remember hiking to one of these villages. It takes many days to actually reach them. And what I noticed was an interesting lifestyle. The women used to wake up early in the morning, and they would feed, the cattle and take care of the livestock. Then they would bundle up their babies on their backs, and they would go and work in the farms. And this is quite unusual to see women who are doing most of the farming compared to men. And the men would stay home. I'm not quite sure what the men did, but they stayed home. And apparently, the reason for this was that in these villages, in these Himalayan foothills, the men pay a dowry to the woman when they marry her, unlike most of what you hear about dowry in India. And so, because they have paid that dowry, they feel like they don't need to do anything else. So, these poor women are the ones who have to take care of all the issues related to their households. So, these women are quite overburdened with work and with family issues. They're often undernourished. They don't have access to healthcare. So think of the integrative approach that one would have to use in working with even nutritional issues with these women. And I remember seeing a young woman when I was there. She was apparently about 13 years of age, and she was being carried like in a palanquin because they have no other way to carry an ill person. And she was really bloated and looked very yellow, like as if she had jaundice, and she was in chronic pain. And they were now going to go with that palanquin 2 3 days till they reached a motorable road, where they would then get a bus or something like that and then go to a nearby hospital for care. Okay, so the prognosis in conditions like that is extremely grim. And unfortunately, there is not much healthcare there. So these women often may be 20 years of age, but because of what they experience in their life, they look like they're 40, 50. They've been ravaged by childbirth. They get multiple UTIs because they go to work in these fields. They carry no water with them. There's a lot of stress, and there's a definite lack of access to healthcare. I remember meeting another woman who told me that she, for many years, had suffered from severe abdominal pain, and she managed to get to some healthcare place near the village. And they kept telling her there was nothing. She went apparently many times because the pain was quite bad. And eventually, they said, okay, this is something you're imagining, and they put her on some kind of psychotic medication. And once she eventually managed to get to an urban area and get herself checked up, they found that she had really severe gallbladder stones, and she had such bad tuberculosis that when they did an X-ray of her, chest and frontal cavity, her diaphragm actually was shifted up because of all the pus and infection from the tuberculosis. So this poor woman for years had been told that she just had like something in her head where she imagined a disease. So when we think of how we work with these women and the integrated lens, look at the social setup that these women are in. Okay, these women are responsible for everything. When they even come home in the night after working in those farms, they have to hull the rice, and everything is cooked from scratch, so it's much more time consuming for them. Their cultural norms have dictated that they marry very young, so they have multiple children by the time they're in their 20s. I remember meeting a woman who told me she was 11 years old when she got married, and she was so scared because she had no clue what married life was about, that she used to go and sleep in the bed with her mother-in-law because she was terrified of her husband. And of course, the economic situation. These women are the breadwinners of the family because they're the ones taking care of the farm and the animals. But when the trade and barter, whatever is done, it's the men who handle the money. So these women really don't have access to, income. And the healthcare is very remote and often not very good quality healthcare, as the woman with gallbladders would attest to it. Okay, so our integrative lens would make us think of how we should approach this issues with nutrition and health in a place like this. Now you see this slide, which is the city of Bangalore, where it's also now called Bengaluru. And I have done some work here with an organization called Center for Advocacy and Research. This slide is from an Australian aid agency, but it shows, it says, this population in the slum that where they are has 626 people who rely on 4 latrines, which is the word for bathrooms, and 2 cubicles to bathe in. When I did my work with urban slum women, I saw very similar situations where there were people who, I remember going to one slum where there were 160 households and there was one bathroom. So the women had to wake up at midnight to start using the bathroom so they could all make it out to work by 6:30 in the morning. Okay. And it was quite a stressful situation for them. If we look at it once again with your integrated lenses, socio-economic issues, health issues, cultural issues, okay, multiple households are using one bathroom. Think of the health issues. There's a risk of, infection. There's very poor sanitation, lack of water, socio-economic issues. These women and these households cannot make their own bathrooms. Usually they end up being there because they rent property, and the landlord is not going to do that because of cultural issues that dictate that a poor person does not even deserve a bathroom. And, as I said, there's not enough water. These women are culturally the caretakers of the family. So not only do they wake up so early in the morning, or midnight actually, to make it out in the morning, but they also make sure, they have food for their children. Most of them work as domestic help in households. So when they go to where they are cleaning dishes, cleaning the house. It may be noon before they get to eat anything. So these women are often anemic, tired, stressed out, and they have very low calorie and protein intake. So we have to, when we get somebody like that, we have to look at what all are issues they are exposed to that need to be, addressed in a very integrated fashion. And this integrated approach is not just something out there in another country. We can even think of it in our own backyard. I lived in Chicago for many years, and I remember there was a big low-income household, uh, what they call projects, called Cabrini Green, very close to downtown Chicago. And in areas like that where there may be high crime, not many people own their own cars. There is very scant public transport. No grocery store wants to open up shop in these areas. When I say grocery store, means like larger grocery stores. So the food source for a lot of these people is the local bodega or your neighborhood grocery store. Those stores are not going to cater to high end, not shelf stable kind of produce, even frozen products like that. So they will sell junk, like as you see, highly processed foods, high in fat, high in salt, high in sugar. And so if you have a person who is living and consuming this kind of food because that's all that's accessible to them, and they may become overweight and obese. And when they come to you and say, I have a weight issue, and you say, well, I think you should, eat more fruits and vegetables, then we have not looked at it with an integrated lens. Okay, we have to see what is happening in their backyard and how should we approach this. Of course, there is a lot of public health kind of focus to this. So switching my lens back to India, India is, you can see in this image, a lot of construction and growth in India. It's one of the 10th largest economies in the world right now. And it has a population of 1.32 billion people. It's estimated by the year 2028, it'll be 1.45 billion people. I have no idea how they will all fit in there, but what we see now is that there's a big percentage of the Indian population that's living in urban areas. 32% currently now lives in urban areas, and by 2020, it's projected that this will go up to 35%. And this is a shift that will not only have an impact on their health, but in what they consume, their lifestyle. So this is a big change in a country like India, where majority of the population used to live in rural areas prior to this. And what has happened is, with the shift going into urban areas, the diets of the Indians has changed, especially when you look at rural and urban. And if you see in this slide, you can see that there some of the foods maybe don't look like it's that different, but fruits, the urban population is consuming more, and you may think, wow, that's really good. Yeah, it is good, and it's because they also have more disposable income that they can use to buy fruits. Animal based products like milk and curd, which is yogurt, and eggs, it's definitely the urban based population that's consuming much more of these. The chicken and the meat looks very close, like 2%, and that is because often meat and chicken intake is quite underreported in India because of the social and religious taboos related to eating meat. So it is definitely increasing, but it is underreported. It's India used to be a country where 60-70% of the population used to be vegetarian, but now it's only 40% of the population is vegetarian. And this pattern of change in intake is because of what we call the nutrition transition. And you will see this term come up a lot. And it's a term that was coined by Dr. Popkins at the University of North Carolina at Chapel Hill. And what is a nutrition transition is, it's a shift in the lifestyle which is due to changes in economic status. Okay, countries like Brazil are experiencing this. So as the economies improve, there's more disposable income, and the patterns of lifestyle changes. And it usually starts, this is the transition begins with people who are actually in the beginning living a more agricultural, agrarian lifestyle where they, farm and they're physically active. They eat food that's seasonal, food that's fresh. And as the economic status changes, there's a shift in the physical activity levels, in the dietary patterns, and all this leads to a lot of non-communicable diseases, which are also called chronic diseases. And eventually, down the spectrum, it's believed that the burden of disease becomes like such a big draw on the economic outcomes that there is a real big push to reverse this trend. But according to Dr. Popkin, really no country has started reversing this trend. Even in the US, we are still seeing an increase in overweight and obesity. And in countries like India and Brazil, and all this is quite prevalent. So the factors that are causing and influencing this nutrition transition are like urbanization. We have, as I said, many more people now moving to urban parts of India because of job opportunities where they can, have better economies, technology, income, global trade. And if you go to India now, you will see fast food, Western kind of foods are very, very popular. This is McDonald's in India, which sells, it doesn't sell beef products, but it sells chicken based burgers and all. But it does have a lot of vegetarian options also because of the population. But extremely popular. If you go into the malls where a lot of fast food places are like Kentucky Fried Chicken and all, they have long lines packed all the time. Often children, will eat all the meals there if they can because it's such a status symbol. There's a lot of peer pressure. You look really cool when you're going to a fast food place for some reason. And so, unfortunately, on the bottom of your slide, you will see a traditional Indian meal with two, unleavened rotis and some vegetable and lentils, very balanced diet. But the majority of, especially the young people, would definitely not want to have anything to do with a meal like that. And that has resulted in increased calories, increased sugar intake, fat, highly processed foods, animal based foods, and a decrease in whole grains, physical activity, family meals, and traditional foods. Families used to really like work together and people would prepare meals. That does not happen anymore. And it's quite a pity because a lot of people either, buy quick to cook foods or, highly processed foods. A lot of people have much more income, so there are lots of cars in India. In the town of Bangalore, if I want to go from where I live to the city, which is only 10 miles, it takes me 2.5 hours. It is so packed on the streets if I drive in the car. Um, that's an unfortunate thing because it also adds to respiratory disease with all the pollution. There are very few sidewalks or no sidewalks, or the sidewalks are a real challenge to walk because it's up and down and holes, and you have to just keep looking. So they're not like conducive to physical activity. And there are very few parks, and this is a pity because for children, that takes away a place where they could actually go and play and be physically active. And this is what we were talking about earlier, is the double burden of malnutrition, which you see in these developing countries like India. There's undernutrition, where there's wasting, stunting, nutrient deficiencies, and then we have overweight and obesity. And this can happen within the same household. You can have a parent, either parent is overweight, obese, or a child is overweight, obese, and the parents are, undernourished or, average weight. And it leads to a lot of non-communicable diseases and these diseases would be with these people for the rest of their lives. And so we have undernutrition, we have overnutrition in India, both at the other end of the spectrums. And for public health, this is a big challenge because you have to deal with issues that are so far apart, and you have to decide which is more important, how you're going to shift your priorities, which needs more attention. So you can see from this image that we have overweight and normal weight people or underweight people. In India, 14.5% of the population is undernourished, and 5% of the population is actually obese. And the obesity is not just among adults. It's estimated that 2 to 3% of even children ages of 10 to 19 are obese. And so while we, have uh, a lot of undernourished and hunger issues, there is a lot of issues with overweight and obesity. And the country is bringing in, despite all this, a lot of processed food companies are being brought in. And the reason what they say is that even though India boasts one of the world's largest consumer markets, and it's one of the largest producers of milk, fruits, vegetable, grain, but it does not have the infrastructure to process these materials. So for many years, whatever was left was wasted. So now the government says that we are bringing in these food processors to help use those products, which is fine, but they often may not be offering the most healthy options for the population that they're producing this food for. So we have 1 in 4 children in India is undernourished. Even despite having quite a good economy, India suffers from a lot of hunger and undernourishment problems. And this other number always stuns me. 3,000 children in India die a day from poor diet-related illness like diarrhea or communicable diseases, parasitic infections that would make them compromise their health. So it's quite a grim aspect for uh, some of these, especially children. And there are different data for children. There's like data on stunting and wasting and underweight. And if you're not familiar with it, stunting is low height for age, and wasting is low weight for height, and underweight is low weight for age. And if you look at the literature on hunger and malnutrition on this aspect of the spectrum, there's a lot of talk on stunting, which is the highest percentage here, which is the low height for the age, because stunting is a very permanent indicator of poor nutrition. Okay, it often happens due to intergenerational poverty, poor maternal intake, maybe poor intake in early childhood nutrition aspects, and also repeated episodes of illness in childhood. And it is said that the effects of stunting result in a 10% decrease in the future income over the lifetime of the stunted adult. It's not like these children need to be stunted, because there is data showing that children who migrate out of India to maybe a Western country may actually achieve much, taller height for their age than they would if they lived in India. So it's unfortunate, and as I said, it's intergenerational stunting and the impact of what happens. I remember going to a school that was for blind children, and there were many blind children there, which was kind of surprising to me. And I asked the person who was running it, how come these children are blind? Like, what happened along the way that made them blind? And I was surprised when she said that most of these children are here because their mothers during pregnancy did not have adequate nutrition and adequately healthy nutritional intake. And so these children were actually born blind, which was kind of surprising. So these impacts can be, as I said, lifelong. And more recent data that compares stunting, wasting, underweight in India, and this is a survey called the National Family and Health Survey done in India. It shows that the numbers are going down. So you can see for stunting and for underweight, from 2005 to about 15 and 16, it's gone down. But the wasting has actually increased, which is the low weight for height. Wasting is often a more short-term malnutritional condition, and it occurs, of course, due to food deprivation along with some serious illness, and it can be easily reversed. Okay, so there are a lot of interventions that are available for taking care of wasting. Not that it's okay to have wasting there, because anybody whose health would be impacted like that would have an issue. And as I said, it's intergenerational. Okay, so we have poor hygiene in these populations. Think of our slums with one bathroom for 160 households. Nobody's cleaning them between use. They must probably absolutely horrible. Especially children who have to use something like this, there's a lot of risk of infection, which would deplete their bodies of nutrients. Then we have added to this mix new mothers who are adolescents because they get married at very young age, may not have access to enough food. 75% of these women are often anemic, iron deficiency anemia. They don't gain that much weight during the pregnancy, maybe 5 kgs. And these malnourished adolescent girls often, and in most cases, do not deliver very healthy babies. They're also living in an environment where women are not given much priority in a household. So they may be abused, domestic violence. When there's no abuse or domestic violence, women are often the people who eat the last in the house after everybody's eaten, and so they may not even get enough to eat. So there is a negative impact on their nutritional status, and it does have an impact on their ability to have a healthy child. Once they have a child, they often do not know how to feed and take care of this child. Sometimes they may even feed the child, formula made out of, water that's not healthy, and the child may end up having diarrhea. In India, there is a lot of childhood diarrhea, and about 136,000 deaths occur per year in children due to diarrhea. And many people don't even think diarrhea is a big deal or a problem because it reoccurs so much there that it's almost like considered normal, and people don't even seek help for it. 136,000 children dying every year actually may be underreported number of deaths in children from diarrhea. So when we look at an image like this, I want you to think of it with an integrated lens as to how we would deal with all these nutritional and health problems that these women and children may actually face. So this is the spectrum of the hunger and undernutrition, but as I said, we have overweight and obesity also in India, and it's leading to a real high increase in non-communicable diseases. And along with that, we have, as I said, undernutrition, which leads to a lot of communicable diseases like tuberculosis, cholera, diphtheria, and of course, a reduction in the amount of poverty that, uh, increase in poverty and inability to function to their normal levels. And this happens at a national level, and it also happens at a household level, and it can happen anywhere. Whenever we have especially non communicable diseases, which were recently often called just chronic diseases, the impact economically can be quite serious. In the US, for example, if one person in a household is obese, that household will face an additional annual healthcare cost equivalent to 8% of its annual income to take care of the obesity issue. In China, if somebody is diagnosed with type 2 diabetes, it usually results in an annual 16.3% loss of income for those with the disease. So the impact of these, because of their impact on the economy, is why something is going to actually be done about these conditions for non-communicable diseases. So almost 6 million people die from a non-communicable disease, usually heart, lung, stroke, cancer, diabetes. Some cities in India are so polluted, like I remember when I was there, the city of Delhi had been labeled as the most polluted in the world. And it was said that if you went out and walked around, it was like the equivalent of smoking like 30 cigarettes. Okay, that's how polluted it is. And 1 in 4 Indians risk dying from a non-communicable disease before they even reach the age of 70. This shows you mortality, like the percent of total deaths, all ages, for the different non-communicable disease, and of course, 37% from communicable disease and 10% from injury. So you can see cardiovascular disease, 20% of total deaths in India are due to cardiovascular disease. There is, of course, diabetes, which is what I would like to talk about a little bit. Although it's only 2%, the diabetes in India is quite unique. Many people call India the diabetes capital of the world. And there are currently 65 million Indians who have type 2 diabetes. So this is just only talking about type 2 diabetes, and it's expected by 2030 to be 100 million people. Indians develop type 2 diabetes at much younger ages than what the normal spectrum is, and at much lower body weights than any other population. And there are several things that have been attributed to this. Of course, there's dietary intake, sedentary lifestyles, but there's a big genetic predisposition. And one thing is it's the body type of an Indian person. They have skinny legs, and the upper torso is skinny, but the middle truncal part is often uh, obese. And this truncal obesity is highly associated with the developing diabetes, with increasing your risk for diabetes. And there's a new theory that's also come, which is called the thrifty phenotype hypothesis. And the authors who put this out propose that when there is so much fetal and infant undernutrition, there is actually maybe a reduced growth of some of the organs, and they think that maybe in the Indian children who may be under, nourished and suffering from that, that their pancreas are actually maybe reduced in growth than a normal pancreas, and so this eventually leads to a reduced glucose tolerance in adulthood. So there is a lot of variability in the issues, but diabetes is it's growing by leaps and bounds in India, and many places it may even be underreported. And of course, there is a rural urban difference with less prevalence in rural areas in India. Of course, the World Health Organization has this lovely sustainable development goal plan to end all malnutrition by 2030. And if you see the slide, number 2 says zero hunger, okay? And then we have, let's look at this, as I said, with our integrative lens. We need clean water, and we need, sanitation and life below water. And you may think, wow, how is all this, helping us? The unfortunate thing is, as it was mentioned earlier, that the zero hunger goal number two is actually going in reverse. It's increasing and not decreasing as the World Health Organization would like it to be. And the latest report that just came 2, 3 days ago finds that 821 million people were undernourished last year. That is 6 million more than the year 2016. So the trend is not going the way the World Health Organization would like you to have it go. And this relates to the same, sustainable development goals, but with nutrition as the focus. And it shows that for every $1 that we invest in making sure we get good nutrition, good health, we will save $16 in healthcare costs. And it ties in all the sustainable development goals with nutrition. So, yes, we have one that speaks out clearly, zero hunger, which is number two. Uh, Number six talks about clean water and sanitation, which is related to 50% of malnutrition is actually linked to poor sanitation. And if you look at quality education, if there is, better education of parents or better education to teach about nutrition, we would see a decrease in nutrition and health related problems. So you may say, well, this is lovely. What is India doing about it? That's the World Health Organization. And this, India has had some programs to, work with the hunger, and there's less that's working with the non-communicable disease related to obesity and overweight. Uh, but they've done some work in the past with hunger, with success in some and not with some. And this one called Poshan Abhiyan is just come out and has been announced in March of 2018. And the Poshan actually stands for Prime Minister's overarching scheme for holistic nourishment. And Abhiyan means it's a mission. And the mission of this is to have a hunger-free India by 2022. It's a great goal, and hopefully it can be achieved. So they are looking at stunting, undernutrition, anemia, and it's aimed for young children, women, adolescent girls. They have specific numbers, like they want to reduce low birth weight by 2% every year. They want to reduce stunting from the 38% to 25% by 2022. So they may not achieve complete eradication of hunger, but it may get there. So this is a great program, I think, that the government has, and it's community based, which is very uh, effective in a lot of Indian scenarios where people have to go from home to home to encourage people to participate in these programs. But of course, we have the epidemic of obesity and overweight creeping in there, and there's still not much that is being done from that. And I say, one of the best lessons learned, I think, is from the epidemic of tobacco. We know where the tobacco control was like a classic case of taxation, advertising bans, smoke-free environments, legislations, to quit like programs for quitting, social marketing, education, and it's the impact in the US has been just tremendous as to how tobacco smoking has gone down. So I think for overweight, obesity, the Indian government will have to work with something like this to encourage not eating such highly processed foods, decreasing intake of fast foods. One of the, if they have even started a scheme where like a ad on the radio for especially for rural people where they have a Bollywood star who comes and gives a little message, and that is often quite interesting and maybe workable in India. So I think it will have to be an integrative approach, which will take, you know, look at the root of the NCDs in India and how it can work, and it has had to be multiple agencies, public, private, even parents at home encouraging their children not to eat so much junk. So I want you to think of, nutrition as one of the most, you guys are nutrition experts and you have a really important job. And we need to step away from the tunnel vision of how we may treat a patient. I think it will expand the scope of our practice. And this was a Chinese proverb which said, if you want 1 year of prosperity, grow grain. If you want 10 years of prosperity, grow trees. And if you want 100 years of prosperity, grow healthy people. I put the healthy in there because Indians think there is prosperity, but it's not necessarily translating into everything is healthy. Thank you. And I'm going to put on my webcam so we can see you. Do you have any questions?
Thank you very, very much, Dr. Archer. That was, for me, that was wonderful. I've learned about some of this in school, and hearing it firsthand from you um, kind of makes it real.
Right.
Whereas before it was textbook information. So, wow, I'm
Right.
still a little in shock.
One thing I wanted to say was for the students who, if when you eventually do research and or you want to expand your horizons, I think there are a lot of opportunities to work with agencies that may work overseas or hook on with somebody who's doing research from here overseas. So I think there's what you will learn and see is just quite incredible.
That's super. Um, I'm going to open it up to questions from
Okay.
the audience. I have a few, but I'd like for
Okay.
them to kick it off.
Okay.
Monique, did you have something you wanted to address? I don't know if she can get audio. She was surprised to learn that um, the rural areas had lower consumption of fruits as opposed to
Yeah.
the urban area. So
Right.
can you explain maybe the little bit of the agriculture in the rural area?
Right,
Um,
right. The rural areas, they're extremely, well, what has happened now is a lot of people have left the rural areas or are leaving the rural areas to go into urban areas to make some money, which is understandable. Uh, and a lot of people own very small pieces of land. Okay, this is not your American farm of, 300 acres and all that. They may own 1 acre of land if they're lucky. Many of them actually work, like do the farm work for somebody else. So they may not have access to, just eating off the farm kind of situation. And India has had a lot of climate change issues. There's a lot of flooding nowadays, and with the other side of the thing, with the famine and drought. So many times the rural areas are the ones that suffer a lot because of those kind of factors. Does that make sense?
y- yes.
They
So
actually, so as I said, they may be growing the, bananas or whatever, but, it's a very small farm, it's tight, so they may not say, yes, family, come on, let's eat, 1 dozen bananas today because they have to sell it to make money. So and in many places it's not their land, so they can't even take anything.
right, and how much diversity of produce and such can they? can they afford to grow in that land, that small area, to really
Not much.
diversify their diet?
Right, right. And with the growing economic trends of change and urban, migration to urban areas, many of those farmers are just losing their farms and selling them off because the cities are just expanding. I keep a house there which was surrounded by farms. If you come today, there is not one farm around.
Wow.
So, yeah,
Wow.
people are shocked. Yeah. So
C-
it's changing a lot.
Can I ask so you were in these villages, if you will. What
Mhm.
were you doing as a nutritionist there or a
I would,
researcher or
of course, like some of those women I paid for their care once I found out. Like I went with a bunch of students and they were collecting, like they did a health questionnaire, because we couldn't carry, much equipment because you were literally walking with a backpack, and they would measure height and weight and things like that. So it was very simple kind of thing, but they were trying to see. I think it was just an eye opener for them to see, wow, there is, quite a big divide between where those students came from and these people in these villages lived. It was just shocking even for me. I hadn't hiked up there. And the urban areas, I mean, there's just layers and layers of issues involved in those women who live in the slums, beyond just the lack of sanitation and poor nutrition. There are some government programs and they need IDs for that, and they're not educated, so they can't get the IDs. They go to get the ID. The man behind the counter laughs at them and sends. So it's just like quite difficult for them. So you get to work with all that kind of stuff.
wow. Other questions from the audience?
I had a question,
Yes.
Dr. Archer. This is Noel speaking, by the way.
Hi.
I
Yeah.
wanted to know how the Ayurvedic practice fits into all of this because it's very, well, I don't know that it's very publicized in America, but
Right.
it seems to be a big part of the culture. That's
Right.
what they
Right.
teach us. So
Right.
I wanted to know in India, and I know India is a huge, very expansive place, but how does Ayurveda factor in?
Very, very popular. It's almost like, for those who know it, the younger generation may be moving away from it a little bit, but
Hmm.
uh, it's like a everyday lifestyle kind of thing. You talk to people and they can just rattle off, do this and eat that and take this. There are entire institutes of universities offering education in Ayurveda, and
Hmm.
there's a lot of plant-based kind of medicinal awareness, like quite incredible and very interesting, and used like on a daily basis, especially in the rural areas, much more
Okay.
than the urban areas. Very, very fascinating. They use it like the arm is broken and they'll get some leaves and put it on a pan and put it on the arm and it feels better. I mean, just like,
Right.
yeah, it's quite interesting. A great,
Okay. Thank you very much.
yeah.
Great
Thank
question.
you.
Hi, this is Kathleen. I just wanted to ask Dr. Archer. So you mentioned that so these rural areas they're faced with so many problems. It's not just nutrition. It's their access and the way the way their livelihoods are. So I mean, when you were there, how were you able to give them like even small solutions to improve their health? Because it seems like it's such a very big challenge.
Right, right. It is. And I think you have to begin with, at least my focus was trying to work with the women because the men were not very interested, uh, or they, and like out of those hills, the men usually worked, so you didn't see them that often. And you had to like convince them, but you have to be do it in a very gentle way of like what is happening. When I volunteered at that little hospital, community hospital in the hills, I would see women who would come from rural areas, and it took them a long time to come there. They were like really quite ill, and the lines outside, and there was no nutritionist in this hospital. Okay, so yes, there are nutritionists in some hospitals, but believe me, it's not common in all hospitals. The line used to be so long in that hospital for people waiting to see me. It used to be like exhausting for me. But you have to just, you have to work at their level, and a lofty idea of saying, oh, reduce your carbohydrates, because you have diabetes may just blow over the head and they may not even understand it. So it has to be done in a very culturally sensitive way, and often they may say something and you may say, oh my god, who told you that? But that also has to be dealt with in a very culturally sensitive way, because they may not agree with it. But one thing is they in awe of the medical professionals, so often they will listen to your advice, especially if you go along with some physicians and all that.
Hmm.
I mean,
Cool.
I had really good success, and in some places I didn't even speak the local dialect, but I had so many women, coming to see me in those urban slum dwelling women that I worked with. So it was quite rewarding.
Can I ask, were they coming to see you for themselves or for their children
I
primarily?
mostly went to maternity clinics to see what
Okay.
the issues were with this NGO, because these women can't even make it to the hospital often on time because they have no means of transport. They cannot afford any transport. So we were trying to advocate for the government to like put some money for them for getting an ambulance and things like that.
Yeah.
So
Wow.
yeah, very simple things.
What we take for
And
granted.
then,
Right, right.
Dr. Archo, going back to the slums, you had said that the young ladies are as young as 11 years old. How old are the men?
Hmm.
Uh, they may be 14, 15, a little bit older. Yeah,
Okay, okay,
yeah, they're not that old, much older. Mm,
okay. Thank
right.
you.
Yeah, I mean, there was a generation in India, like my grandmother was married when she was 13, but this is still going on today, so it hasn't changed.
Wow. Other questions?
I do have one.
This is
Um,
Jay.
yes, this is Jay. So my question is, it seems like there are some lofty goals that they have there. Would you say that it's more of a resource issue, or is it just they don't have nutritionists to give the information that they need?
When I worked with those urban women, they have these like what they call Anganwadis, and like these women who are trained as community workers. They're quite good, but they don't. The government doesn't pay them enough, so they've lost a lot of them, which is unfortunate because they were really well trained to do community nutrition. And then what I found out was the government gives like each household in these slums, so much rice and wheat and sugar and all, and they have to go to this one center and get it. Uh, but the people who run that center apparently take the majority of it, so they barely get anything, So
Oh, wow.
that was a sad thing to see, because I mean that was a good opportunity. So the government has started like school lunch programs for low income schools and things like that. But I think the focus has not been there, and a lot of public health uh, you know, money support has not come in. Till quite recently, the government just depended on outside funding and things like that, and they really need to bump it up themselves, because to eradicate hunger in the time period that they've chosen is quite a big job. I mean, and I've been to like really posh hospitals in Bangalore, And I looked at the board, and there was a physical therapist and an occupational therapist, and physicians, etc. But there was no nutritionist.
Mm.
Mm.
It's
Thank you.
not all hospitals, but yeah, many still. You know, the doctor does the nutritional work, I guess.
Well, that's kind of how it is here too, where nutrition isn't really as integrated into the rest of um, the medical system. Wouldn't you
Right,
agree?
right. But I think it's changing a little bit. I mean, I've
Yeah.
seen, especially with the integrated approach, where the physicians feel like, okay, they can work with a nutritionist to do some of the work. And that was one thing I loved at Northwestern was I worked in the Department of Preventive Medicine, and it was all physicians, but very pro nutrition, which is not something you see that commonly. So, I think they realize the importance of nutrition and, prevention of disease. So, and I think the culture is changing.
Yeah, I hope.
Yeah.
This is Monique Jackson. Sorry, I'm on again.
Hi.
Can you
Hi,
hear me?
Monique.
I'm sorry.
Yes.
Hi, Dr. Archer. Thank you so much for all this information and a cross-cultural sort of educational experience here. I appreciate you doing that. I guess my question is, do you think that education would change things, or is this more of a cultural, like, does education have an impact? Because I feel like even in America, you can educate somebody, but there's such a fast-paced culture in our society, and I guess you can say the big L word, lazy, to
Yeah.
sort of cook and take the time to make a healthy meal, to sit down together. Do you think that in India, education would sort of like cut across those?
Yeah, I
Like,
think
would
it
they be
can.
more receiving?
Yeah, I think it can. It depends on who you're dealing with. Like, let's say the obesity and overweight, which is in a more upper income segment or the and middle class segment of the population. I think social media could be used for education and make it more specific with that kind of thing in mind. But for the undernourished, it will be a challenge because you may not be accepted. Trying to go in there and say, "Look, I've come to." Tell you about what you need to eat because uh, they have so many other issues on their mind. That's why I think integration is really key. You have to address so many things. So it's like taking somebody who has a eating disorder here. They see a nutritionist, they see a psychiatrist, they may see a nurse, they see a physician, they see a social worker. So it has to be a team approach like that.
Right, right. Okay. I guess that their battle is a lot stronger because they're trying to just survive
Mhm.
Yeah,
day to day.
exactly.
They,
Right. So,
survive from infection, from
right,
disease, from
right. So,
uh,
we have to start providing them, the clean water and the bathrooms.
right.
And there's a big push in India to try and, start making bathrooms. It hasn't gone very far, but hopefully. And, I
Yeah,
thought,
it's huge.
and then I actually found out, I said, how much does it cost to make a bathroom? And my next goal is maybe go make a few bathrooms in some of these places let you. I mean, so
Maybe the IFN program can sponsor a bathroom or two.
right,
That would be
Yes.
awesome.
That would
Yes.
be really good.
change
Um,
and impact. Yeah.
have you seen like the Vitamin Angels or any
Yeah, vitamin
organizations like
angel.
that go in? I mean,
I
it's only
haven't seen.
chipping.
Yeah, I haven't seen that, but the organization, the NGO I worked for, was partly funded by the Bill and Melinda Gates
Ah,
Foundation. So that kind of thing I've seen, but I haven't seen vitamin angels. And I mean, when I was there, these nuns had come to see me, and they actually run a free health clinic for women and pregnant and non-pregnant and they were just begging me to come and sit in the clinic and give nutritional advice to especially the pregnant women. So there's a definite need for expertise and public health, you know, uh,
Yes.
options there.
Wow, it's sad that it's the government is not doing more and it's so reliant on
Right,
external.
exactly. And I think the education system, I mean, there are a lot of physicians who work with public health, but there are not many nutritionists, who are trained to work in public health and issues like that. So
Mm,
you have external organizations like a WHO or somebody who may come in and, put somebody, but a lot can be done.
yes, a lot needs to be done.
Right. And the research opportunities, the education, I think for a lot of people here is quite incredible if you go out and see.
It really is a lot of research opportunities
Mhm.
and grants to support that research.
Right,
There are. I mean,
exactly.
you just mentioned the Bill and Linda Gates, so
Right.
lots of opportunities.
Mm.
Other questions from those in attendance?
I was just going to make a comment. It's Melissa. Hi.
Hi, Melissa.
Hi. Thank you. This has been very, very interesting, and a little sad. It's very sad to hear about the struggles that so many people over there
Mhm.
face. It's
Mhm.
heartbreaking. I
Mhm.
hear, I'm thinking about, you know, you can give advice, but if the resources aren't there, what good is the advice? You need the healthy food.
Mhm.
Advice can only go so far.
Right. Something has to be put into place to help these families, become self-reliant, but in a, positive way. And little things like if they have access to clean water, I mean that
Mm.
child is not going to not be able to wash their hands and eat their food, because Indians don't use toilet paper. I don't want to go down that path, but and that's where we are looking at infections and parasitic infections can be quite serious.
Ugh,
So,
So health education looks a little.
yeah,
It's not always
right,
nutrition. It's other kinds of health
that's right.
education that affects health.
right. So as I said, it has to be integrated.
Yeah.
The nutritionist, you may need a health educator, physician, whatever.
Yeah. It's definitely not one piece.
No, right.
Anyone else? Well, I don't want to ignore anyone's question. If you have anything, feel free to interrupt me. I do want to thank Dr. Archer for coming tonight to speak with us. This, for me, is, I was going to say, a great way to kick off the semester. However, it is a little, we've got our job cut, the world has their job cut out for us.
Right.
So, wow, it's very insightful. And hearing directly from you who have that firsthand experience, I think, made it that much more impactful.
Right.
I really want to thank you for putting that hurricane flow on hold for a little while so we could get
Right.
through this tonight. Yes, everyone, Dr. Archer is in the middle of North Carolina, which is expecting some pretty high winds and potential flooding, but she told the hurricane to slow down. Um, and hopefully you'll have Dr. Archer in class sometime soon. And I would imagine if anyone has questions, they could possibly reach out to you via
Yeah.
email.
Yeah.
Yeah.
Yeah, please
And
feel free to contact me, with any question or something that interests you, which I can help you with.
yeah, Wonderful, thank you. Well, I hope everyone that is in the wake of the storm is doing well. And I want to thank you, Dr. Archer, for coming tonight.
Thank
So
you.
on
And
that,
thank you for giving me this opportunity.
yeah,
Thank you.
I'm applauding. So this is recorded, and I'm excited to share it with others. So thank you.
Okay. Bye-bye.
Have a good night, everyone.
Thank
Thank
you.
you. Thank
Bye-bye.
you.
Thank you. Bye.
Thank you so much.
You're welcome.
Bye.
Thank you. Bye-bye.